Can somebody record the session?
It is being done, sir, automatically. We need
Oh.
not inform them.
You share
Every
me that
session is
link
recorded.
later, no? Because, yeah.
Deepen, are we live on YouTube?
We have started the recording.
Are we live on YouTube now?
Yes, we are live.
Dr. Sarita Madam, I think you take over and please introduce the faculty and the case that is being presented.
Okay, sir. So a very good afternoon, everyone. So for the today's IAP Pune PG case discussion, the case is being presented from KM Hospital Pune, and Dr. Mandeep Nanda, who is a third-year DNB resident, is presenting a case of a 9-year-old female child with recurrent respiratory tract infections. We are so honored to have esteemed faculties with us today. As a guest faculty, we have Dr. Subramanya NK sir, who's a renowned senior pediatric pulmonologist from Bangalore. He's been having many posts in the IAP as well, and presently heads the IAP chapter of pulmonology. Welcome, sir, and thank you for being present at such a short notice with us. As the second guest faculty, we have Dr. Vijay Kamal sir, who is Head of Department Pediatrics, MGM Medical College, Navi Mumbai. He has many research papers to his name and a very active and a cheerful pediatric teacher. And from Pune, we have our very favorite Dr. Mishra sir, who is Professor Pediatrics, D.Y. Patil Medical College, and Consultant Pediatrics, KM Hospital. I welcome everyone on behalf of IAP Pune. So Mandeep, are you ready? Shall we start the case?
Yes, ma'am.
Okay, so all the best, Mandeep. You have a guest faculty who is ex-student of Pandit sir, and he has high regards for KM. So all the best to you, Mandeep.
Good afternoon. Yes.
All the best to you. I was in same seat as you were sitting few years back. Okay, go ahead.
Thank you, sir. Good afternoon, sir. Good afternoon, everyone. I am Dr. Mandeep Danda from KM Hospital, second year DNB resident. Today, I am presenting the case history of Aisha Tambadkar. She is a 9-year-old female child, first by birth order, born of non-consanguineous marriage from Pune. She is Muslim by religion. In informant being mother, she is reliable and graduate. She was brought to the KM Hospital with the chief complaints of persistent bed cough since last 2 years, persistent variable breathlessness since 2 years, not able to put her weight since last 2 years. Patient was apparently asymptomatic 2 years back when she developed cough, which was insidious in onset, persistent, daily without any remission from last 2 years, with sticky and the tenacious expectoration, which is purulent, usually yellowish and occasionally greenish in color, foul smelling, small in quantity after prolonged bouts of cough without any blood anytime. Cough was more during the morning time after waking up and relieved after sitting up for 10 to 15 minutes and nebulization of regular medications. She has worsening episodes of cough lasting for around 2 to 3 weeks, necessitating consultation, added oral treatment, and hospitalization for around 2 to 3 weeks for 4 times with injectable medications and oxygen therapy. She is on daily oral medications for cough and continuous oxygenation. But from last 7 days, cough has increased in frequency, severity, and expectoration amount, with greenish in color, foul smelling, non-blood tinged, and more during the morning time after waking up.
Mandeep, can you tell us what are the causes of wet cough, which is persistent for a long time?
There can be chronic suppurative lung disorders like bronchiectasis, Then mucociliary pathies like cystic fibrosis and primary ciliary dyskinesia. Then lung abscess and the chronic cavitatory TB lesions.
Then posterior nasal drip also can have some cough.
Yes, a posterior nasal drip can also have the persistent cough.
Okay.
Along with the posterior drainage.
Okay. So proceed further.
Patient has breathlessness since last 2 years, which is insidious in onset, with in the form of persistent fast breathing with chest recessions, which was progressive over last 2 years, initially on the exertion, but now even at the rest, round the clock since last 1 year. Her mother monitor her pulse oximetry regularly. She has multiple episodes of breathlessness, which is increased with the cough bouts, physical activity, reduced by the rest, expectoration, and nebulization of some medications. She has waxing and waning episodes of increased and prolonged breathlessness lasting for around 2 to 3 weeks, associated with the increased cough bouts and decreased oxygen saturations. She required increased oxygen supplementation at home and hospitalization with additional device needs. As noticed by the parents, from last 2 years, patient has documented weight which remains in the range of 13.5 to 13.8 kg over last 2 years. She is a poor eater from early childhood, but with a further notable decrease in the appetite over last 2 years. On further inquiry, parents noticed that she has intermittent episodes of diarrhea occurring every 3 to 4 monthly, with passes of large amount of semi-solid stools, non-foul smelling, greasy, non-blood tinged 2 to 3 times in a day, lasting for around 7 to 10 days, resolving spontaneously. It is not associated with a fever, abdominal pain, vomiting, bloating, flatulence, and weakness. Patient has no history of chest pain, bluish discoloration of nails and fingers, tongue and lips. Patient has no history of fever with the ear or facial pain, ear discharge, nasal block, and nasal discharge. No history suggestive of sore throat, pain during swallowing, snoring, mouth breathing, and drooling at the night.
See, you are giving continuous oxygenation. So if continuous oxygen, he is requiring a continuous oxygenation, even home-based oxygenation. So likely that may be having a cyanosis, clinical cyanosis.
So clinical cyanosis is not present. Due to breathlessness, we have to give him a continuous oxygenation.
So it doesn't require continuous oxygen, only during period of breathlessness.
So he has continuous breathlessness.
What are indications for giving oxygen? Because oxygen is a drug. So what are indications for giving oxygen in a respiratory case?
When patient has breathlessness with the suprasternal, substernal, and chest and groins, with the maintaining saturation below 85% to 90%, and with cyanosis.
Sir, would you like to add something, sir? Subramaniam, sir?
No, let him complete history and then I'll come back to him.
Okay. Continue.
Yes. No history of short throat, pain during swallowing, snoring, mouth breathing. No history of eye redness, stickiness or discharge. No history of change in voice, audible respiratory sounds. No history of palpitation, swelling over the eyes, feet, legs, and abdomen. Syncope, dizziness, headache, and visual disturbance. No history of nausea, vomiting, choking, cough while feeding, abdominal pain, yellowish discoloration of skin and sclera, abdominal distension, and change in stool and the urine color. No history of severe, persistent, unusual, resistant infections of ear, nose, throat, sinuses, recurrent boils, oral thrush, and recurrent diarrhea before last 2 years. No history suggestive of joint pain, rash, oral ulcers, and change in hair and nails. No history suggestive of unusual appearance, deformities. No history of contact with any TB person, evening rise of temperature and night sweats. No history of unusual exposure to dust, allergen, pollutants. No history of visual changes, skin changes, joint or bone changes. No history suggestive of change in the urine frequency, volume, stream, hematuria, and burning micturition. No history of any surgical intervention or any blood transfusion. After admission in the hospital, she started on the IV medications, nebulization, chest physiotherapy, Oxygen therapy by small machine. Investigations were done. X-ray chest, blood and sputum were done. Cough and breathlessness decreased after 4 days and oxygen requirement decreased slowly, and now on the face mask oxygenation. Now she is better. She can sleep and eat well with resumption of daily routines. Past history. Patient has history of brief episodes of cough with breathlessness at 4 months of phase, requiring hospitalization for 2 days only and relieved with some IV medications and nebulization. Family history. Child is the first offspring of non-consanguineous marriage. No history of any structural abnormality, significant, recurrent, or unusually fatal medical issue in any sibling or parent. Birth history. G2P2 A0 mother regularly visit to the ANC in a private hospital, receives appropriate timely antenatal care with no history of smoking, alcohol and drug or chronic medication intake, with no history of diabetes, hypertension and pregnancy complications. Baby delivered at the 33 weeks of gestation by normal vaginal delivery with birth weight of 2 kg with clear amniotic fluid, passed meconium and urine within 24 hours, no history of neonatal jaundice after birth, and discharged home on breastfeeds on 3rd day of life. Developmental history. She is studying in the 4th grade. She does well in studies but not able to play outdoor games and have lot of absentees in the school for her frequent health issues. Immunization history. She received all immunization in government hospital till 5 years of age. Additionally, she has received pneumococcal, influenza and typhoid vaccine. Feeding history. She has taken calorie of 1040 calorie with expected of 1700 kilocalorie with a deficit of 660 kilocalorie with protein intake of 23 gram with expected of 26 gram with deficit of 3 gram. Socioeconomic history. Father is a 32-year-old graduate with salary of around 15,000 per month, with mother 26-year-old graduate housewife with a joint family of 5 members, have their own pakka house, clothes, sanitation and drink boiled water. She belongs to the upper middle class family according to modified Kuppuswamy scale with a score of 21 out of 29. Summary of history. She is a 9-year-old school-going girl brought from mid-childhood onset cough and breathlessness from last 2 years with waxing and waning episodes, recurrent mucoid diarrhea, and not gaining weight with normal development. Suggestive of chronic, persistent, progressive, variable lower respiratory tract infection, recurrent mucoid diarrhea with growth failure requiring frequent hospitalization, regular oxygenation, and daily medication with worsening of disease from last 7 days.
Before we go for examination, what are things you are going to consider now with this type of history?
So we will consider chronic lower respiratory tract disorders like bronchiectasis. There can be bronchiectasis. There can be bronchopneumonia. So there can be mucociliary pathies like cystic fibrosis, primary ciliary dyskinesia. There can be chronic cavitative lesions like tuberculosis. There can be left heart failure syndromes, and they can be interstitial lung disorders.
Heart failure symptom present as a respiratory symptom. What are the respiratory symptoms of heart failure, and how it is going to be different from this case?
So the kids were also present with the palpitations and breathlessness while during the night time, and she has to wait for the breath, and she has previously
that is called a
paroxysmal nocturnal dyspnea.
So they'll have one heart symptom. But what question is that how respiratory symptoms are going to be different from this case in a chronic heart failure patient? Say, how is the cough in the heart failure patient?
The cough, it can be, it is mostly mucoid cough, like in the heart failure syndrome.
Pink frothy sputum type of case. It will be more of frothy. It will never be mucoid, or it will never be foul smelling.
Yes.
Usually, heart patient will not have a foul smelling. So, thing
Yes.
which is best heart failure patient is foul smelling and mucoid cough.
Mucoid.
And third thing is there's no variation with the change of the day.
Yes.
Heart patient cough will be more in the night time, early morning and night. Okay.
Yes.
Mandeep,
Yeah.
can I ask two questions?
Yeah. Please go ahead, Vijay.
Okay. So, thank you, sir. You have asked history of ear and facial pain. So, for what reasons have you asked that thing?
So that we have to rule out chronic sinusitis.
Facial.
So facial for the maxillary sinusitis, if there is present, then it can.
Maxillary as okay. And sir, already I asked you regarding cyanosis. So, at what stage of saturation cyanosis can develop? Because they are monitoring, you said, on pulse oximeter and other things. So, and you are not getting history of cyanosis. You said no cyanosis, but child is on oxygen. That means cyanosis could have happened probably, or in the, so what stage, what SpO2 level cyanosis can be clinically evident?
So below 85% of saturation.
So below 85%. And oxygenation, you start at what level? COVID experience?
More 90%. 90 to 95% we start mostly
Below
oxygen.
93, you have to start oxygen. So it's okay. So they may not be evident cyanosis. As far as history of contact of tuberculosis, how did you ask the contact history?
So is there any person around the neighbor and school and the family which is present with a chronic cough, means cough more than 3 to 4 weeks, and on medications for last 6 to 8 months?
Contact is how many years, within last how many years that contact has to be is defined?
Sir, 2 years.
That way contact can be anybody. No proper definition is there, but still in last 2 years, a positive patient contact is nowadays required. Duration is not necessary. So anybody in family having tuberculosis for last 2 years, maybe who is the positive? Putum positive or gene expert positive. You also had asked history of unusual exposure to dust.
Yes.
So what was done for that thing?
Say that I have to ask for any allergic history to the baby or any safe interstitial lung disease if there is pollen, increased exposure to the pollens and pollutants that can also be.
Know that even a small quantity of pollen or even dust can cause allergy. So unusual exposure means I don't know, sir may be expert into that thing, allergy, atopy. So that word may not be appropriate. So usual dust or some this, you can ask history of allergy for something. Okay, this child was 2 kg. So what was the cause of low birth weight in this child? Did you ask? 2 kg at birth.
No, I didn't ask, but there is no specific history of any diabetes, mellitus, and hypertension in the mother.
Yeah, so some cause must be there, no, for 2 kg. So that's in summary. I think you have not mentioned that part. So this child was 2 kg. As far as meconium is concerned, is there any importance of asking meconium history in this child?
So if delays passes of meconium, there can be cystic fibrosis. That is.
Okay. Okay. Last question for this related to history. Protein, you have got 23 kg, child's weight is 13 kg, around 13 kg, no, as you said.
Yes.
Is that not more than what is required? What is your take on this thing?
We have to take the weight according to the age for that.
But this can lead to some high protein load also, can cause some problem also if you take only weight as age as the criteria. So I think some history issues may be there. Sometimes we tend to miscalculate the thing. Okay, so this child is having both respiratory and GI symptoms probably and failure to thrive. So you can, sir, can you go ahead? Subramaniam, sir.
I've got him to analyze a few more things. Now
Okay,
let's
okay.
start from you. Now first you tell me the differential diagnosis at history level. I'll start from there. You have to rectify your approach. That's why. At history level, what are your differential diagnosis?
So my differential diagnosis is the primary mucociliary pathogens like cystic fibrosis and primary ciliary dyskinesia, chronic suppurative lung disorders like bronchiectasis and empyema, and there can be chronic lung disorders like tuberculosis. So there can be primary immunodeficiencies, which is associated with the persistent breathlessness and cough, and they can be associated interstitial lung diseases.
Okay. You have told a whole lot. You're mixing. You are almost telling everything. I think that is where your thought process is not in order. Let me help you out. What is the anatomical diagnosis?
Lower respiratory tract infection.
Lower respiratory tract disease. Forget infection or otherwise. Correct. Lower respiratory tract disease. Is what in lower respiratory tract disease? Is it a disease of airways? Is it a disease of parenchyma, pleura, pleuroparenchyma, airway plus parenchyma? What do you think? First.
Airway plus parenchyma.
Why?
So these associated with the cough, which is expectoration and yellowish and greenish.
So simple. So wet cough, isn't it? Cough will tell you it is airway disease, and wet cough will tell you all the more that there is airway plus parenchymal. What are the other things that suggest parenchymal involvement?
So this breathlessness, which is associated with the fast breathing and chest recessions.
Only airway?
The breathlessness, which is on exertion, and it relieved after nebulization.
So one is airway. I couldn't hear you for a while, but let me take that you have answered. But what it means is that one is airway disease, and amount of sputum is quite significant. We don't expect sputum in a child. Usually in adults we get that history, isn't it? However smart they are, this child has given early morning expectoration of sputum, that too in large quantities, and a postural variation of cough, isn't it? So straight away there is one diagnosis, that is bronchiectasis. Now, as a postgraduate, please don't mix up things. I want to give details like bronchiectasis, TB, then primary ciliary dyskinesia, cystic fibrosis like this. No, that is wrong. See, remember, bronchiectasis is not a diagnosis. Cause of bronchiectasis is the diagnosis. Do you agree? Can TB
Yes.
cause bronchiectasis? Answer is yes. Can foreign body cause bronchiectasis? Yes. Post-infectious? Yes. Idiopathic? Yes. So on and so forth. So therefore, as a PG, don't mix the two. You are mixing the two. Can an interstitial disease give rise to some other sequelae? I mean, pulmonary parenchymal plus interstitial involvement is there, subsequently leading to airway involvement also. They're all different. Can you get even simple lymph node compression? Can it cause ectasia? Answer is yes. Post compression dilatation can be there and can lead to recurrent infections, aspirations, so on and so forth. It can be aerodigestive disease also. Anything can be there. So therefore, first you stick to one diagnosis, bronchiectasis. Now, if I have to know, I'll straight away come to the diagnosis for you in this child. If you have to know the cause of bronchiectasis, what is the most important thing that you need to know? Is the age of onset of first symptom.
Yes.
See, is it neonatal? When did the first symptoms of the child started? Forget the history presenting illness, past history, etc. You take the holistic view of the child's illness. See, bronchiectasis is a disease which can present with recurrences, flare-ups, etc. Do you agree? Whenever there is intercurrent infection. So therefore, let's forget that for a while. Is there any dispute or doubt that it is not a bronchiectasis in this child from the history? Answer is no. You can straight away tell that definitely there is bronchiectasis. We do not know whether it is bilateral, unilateral, only lower lobe. This we don't know. at this stage. But definitely there is history of bronchiectasis. Is there anybody who doesn't agree with bronchiectasis in this child? We have to explain other causes of wet sputum and recurrent presentations or a persistence of cough, correct? That is very difficult by any other disease. We can always differ between us in cause of bronchiectasis. Do you agree? That can be anything. Let's not worry about it right now. Now, can you give me now the child has ended up in bronchiectasis. When the bronchiectasis actually started? Or I'm asking the same question in a different form, when the symptoms started first.
So symptoms may be started before 2 years of age, but the parents may be noticed from last 2 years.
So this is wrong. As a PG, you are telling the current symptoms. That is like typical exam case you are interpreting. But the symptoms started from 4 months of age. Do you agree?
Yes.
Child was hospitalized for 2 days for the first time. And if I say child had cold cough at 4 months of age, I would not have bothered. The symptoms were severe enough to get hospitalized. And hospitalization is for a lower respiratory disease again. Okay. The second argument can be that disease at 4 months of age is different from the current disease. In that case, we cannot say it started at 4 months of age. Do you agree on this point? Correct? No.
Yes.
Suppose that was a simple bronchiolitis or lower respiratory tract disease, and this is a different disease, not connected, then it's fine. But as a physician, we are not supposed to de-link and give one diagnosis every year or every 2 years. Do you agree? We are supposed to take wholesome and take a holistic approach and bring all the symptoms under one umbrella. If we go for that approach, the story of this child would start from 4 months of age till 7 years of age. With how many intervals in between, we are not bothered right now. Now you describe me the intervals, one at 4 months of age, and then again, from past 2 years, it has worsened to the current stage of even getting hypoxia, correct? Now tell me one question, is hypoxia common in an airway disease? Very uncommon.
Very.
Airway disease means I'm not telling about asthma or anything. I'm talking of airway disease like bronchiectasis. This is the last to happen. This is the last to happen. If you examine this child and if there is clubbing, that means hypoxia is there from long time. Probably hypoxia and suppression. Understand? So let's not debate too much on this, but sufficient for me to tell you that you must take those causes of bronchiectasis which can start at 4 months of age. And suppose these two are not linked, causes of bronchiectasis which starts from 5 years of age. Correct? No? From 2 years is symptomatic. Correct? Now tell me the causes of bronchiectasis at 4 months of age and causes of bronchiectasis at 5 years of age. Common 2, 3. 5 years of age, you tell me first. You will be relaxed. Foreign bodies. Forgotten foreign bodies. Correct. Did you ask the history of choking? No. Then history of tuberculosis? You asked. It could be there, it may not be there. Correct? Do you agree?
Yes.
Okay. Unresolving pneumonia. That means there is an untreated, improperly treated pneumonias of various causes. Let's not worry about them. Correct? Sometimes you don't treat them properly, viral or bacterial, they can end up with persistence of diseases. It could be fault with the airway. It could be fault with the organism. It could be fault in the treatment. It could be fault in the immune system or host factors. Any one of them can lead to mucociliary or immune defense failure and therefore the resultant pathology. Are you getting my point? See, fine.
Yes.
Let's not worry about it. What about those? Can you get peculiar causes for the symptom onset from 4 months of age?
It can be primary immunodeficiency disorders, which can
Excellent.
There can be congenital heart disorders, which can lead to
Congenital heart or congenital airway anomalies?
congenital airway anomalies.
Yes, like tracheoesophageal fistula, aspiration syndromes, laryngeal cleft, so on and so forth, etc. Isn't it? Do you have, so therefore your negative history should have asked for aerodigestive symptoms at the age of 4 months. What I meant by aerodigestive symptoms? airway symptoms and digestive symptoms like vomiting, cough, vomiting after cough, or cough after vomiting. Did you understand? Some kind of relation and the way the child behaved. This gives a lot of hint and clue to. We are not expecting this much from you as postgraduate. Did you understand? But I'm analyzing the case for you.
Yes.
Do not worry much. As a PG, if you have analyzed up to bronchiectasis, we are done. But I am going beyond that and trying to find out what could be the cause of bronchiectasis. Correct. Is foreign body likely in this child? Answer is no.
No.
Is tuberculosis likely in this child?
No.
Answer is no. Straight away. So this, I mean, simply by the fact that tuberculosis is no longer a parenchymal and airway disease too early in first 3 months of life, it could be more a miliary presentation. Do you agree?
Yes.
Exceptions apart. I'm not talking of exceptions, please. Generally. Do you agree?
Yes.
So therefore, I will not even worry about tuberculosis in this child. I will be more worrying about congenital lesions or the metabolic defects which can present since infancy that can cause bronchiectasis. Okay. Now, can this be any other disease other than bronchiectasis? Let's come to the second half. Highly unlikely. Don't you think so?
Yes, highly unlikely.
No, why? Because if hypoxia sets in any other disease, they don't survive for 2 years. Only in airway disease they survive. An interstitial disease will worsen quickly. Parenchymal disease will be progressive. Don't you think so? This is relatively slowly progressive disease and
Yes.
patient even tolerating hypoxia. That means it is a compensated disease with an airway predominant manifestation. I'm again right or left, I'm coming back to ectasia of the bronchi and the airways. However you go. Now in bronchiectasis, let us now further go down and see, is it unilateral or bilateral, which is more likely? Is it lower lobes or upper lobes, you think?
Bronchiectasis bilateral is
Probably lower lobes because on lying
lower
down he
lobes.
was correct. And
Yes.
second question is, do you think an unilateral disease will cause hypoxia? Answer is no,
No.
because other lung is fine. So you need 2/3 of the lung involvement anatomically for the child to become symptomatically hypoxic, correct?
Yes.
Extensive lung disease. So you can bet and pretty sure I can tell you the CT findings right now that this child will have a bilateral disease. It will have an extensive disease. I may be wrong, but this is how I guess. Correct. And more than 2/3 of the lung will be definitely involved. And upper lobes unlikely may be there. But you know why? Because for me, for getting good volume of the lung itself, you need to have predominant lower lobe disease. Only upper lobe disease will cause hypoxia. Understood? Now I can be pretty sure that there is no hemoptysis in this child. Therefore, possibly that cavitatory disease or a prominent proximal dilatation is unlikely. So now coming back to the airway, do you think it is larger airway or smallest airway?
Smallest airway.
Yeah, you are almost near it, isn't it? So I have almost taken you even localization of the airways, correct? So now are you comfortably following me up? Correct? No.
Yes.
No, there could be wrong. We see it is not that when we say smaller airway disease, it is not that it will not involve larger airway. Ultimately, everything gets involved. But this approach is required for you to analyze the case. You remember this tip. If
Yes.
cough is more than breathlessness, then it is proximal airways. If breathlessness is more than cough, then it is smaller airways.
No.
Can you repeat for me?
Yes.
In a
If
given child, breathlessness
it's more than the cough, then it is mostly involve the smaller airways. If cough is more than the breathlessness, then it is the proximal airways.
And now in this child, you tell me the quantum comparison between cough and breathlessness, which is equal 50-50 or what is the scenario? Roughly, severity wise,
So breathless is more than the cough.
cough or as much as cough.
As much equal, as much as cough.
Okay, you can say medium to small. It need not be, you need not have to stick to one thing. It can be medium to small airways, fine. Proximal also may be possible, but let's keep our fingers crossed. It could be there. But at this stage, now tell me, diffuse small airway disease with bronchiectasis starting at 4 months of age. Now, if it is a proximal airway disease, I will again go to leak syndromes, aspiration syndromes, TOFs, etc. Got my point? They damage the area where it leaks. Now I'm moving away from aspiration syndromes also. Okay. If you argue with me on recurrent aspirations causing bronchiectasis, here the problem is there should have been episodes linking to vomiting, hospitalization, if it is a macro aspiration. Micro aspiration, at least there should be history of spitting and all those things. You understand?
Yes.
And what happens to those aspirations with age? They will be less reduced, in fact. Do you agree? As the child matures. Now this child has worsened from 5 years of age onwards. So I have to think of a congenital bar acquired disease that would start in infancy, will be progressive, persisting, and causing bronchiectasis. I'm not finding anything other than cystic fibrosis. Okay. Now, straight away, analysis of history itself. Okay. Non-CF bronchiectasis of various causes can also be there in this child, which we will not debate right now. Now, further, how do you proceed? Now, can it be primary ciliary dyskinesia? Yes or no?
Yes, sir.
Why? I will say no.
Sir, no in the means against that there is no involvement of sinusitis and
upper airway symptoms like sinusitis, particularly recurrent otitis media and ear discharge. That is not there in this child, isn't it? So straight away you can take out primary ciliary dyskinesia out of your context. Can it be environmental or acquired lung injury due to persistent toxin damage to mucociliary apparatus of any acquired origin? Maybe foreign bodies, recurrent infections, inhaled toxins, so on and so forth.
there is no history of any exposure to that environment.
That's important. In this particular child, you have to take history of exposure to volatile compounds. Understand, no? So many things, environmental toxins, so on and so forth. That history is also not there. So we have almost covered intraluminal, intramural, and extra luminal causes of bronchiectasis in general. So I've taken you through the journey, but by the way of questions. Now we will go to examination. Now, before we go to examination, what are the objectives in our examination? An examination is going to give us an anatomical diagnosis, correct?
Yes.
But history cannot give us anatomical diagnosis. Now, can an anatomical diagnosis give clue to the etiology? Answer is yes. Because there are causes of upper lobe bronchiectasis, there are causes of lingular bronchiectasis, localized bronchiectasis, bilateral bronchiectasis, unilateral bronchiectasis, isn't it?
Yes.
They give hint to the workup. So you should not be mixing again in investigations and unnecessarily spend patients' money on investigating for everything. I will not put my money on anything, but being in India, I would just do one CBNAT, that's all. More than that, I won't do anything else in this child. Agreed? For example, for tuberculosis, don't go on. Okay. Now you quickly sum up the history and come to the examination. Is that fine for you, or you have any doubts to ask me? You can also ask me.
No sense.
No, you can also ask me. No problem. I'll also answer. It's not that I should be asking you. As a student, you have the privilege to ask anything that you want to see. Now, it's very clear. Is it an interstitial disease? Answer is no, because predominant breathlessness, but presence of cough as a symptom which points to the airways. Parenchymal plus interstitial unlikely. Now, infections unlikely because there is no predominant fever. Agreed?
Yes.
As much as a cough and breathlessness is there, this child has typical wet cough and breathlessness. Wet cough will tell you the origin. Breathlessness will tell you the extent of the disease. And hypoxia will further tell you the severity of the disease. We are almost near the diagnosis. Is this fine for you? Oh,
yes.
Good the examination. Anything else other faculties want to comment? You can. before we go to exams.
Basically, Mandeep, when the child was 7 years old, his weight was 13.8. That means this, as sir said, this disease originated much before than that.
Yes.
As sir has pointed out, because 13.8 at 7 years is really low.
Yes.
And yeah, I think you can also understand sometimes. I'll give an example. This chronic liver disease you must have seen. They don't give history of chronicity. Do you agree? The history could be 1.5 months only, or even sometimes 3 weeks only. But you could know from your examination later on that probably that disease must have started way ahead, like 1 year back or 1.5 years back. Are you not seeing such cases, beta? You agree?
Yes.
You
Yeah, we
understand?
are seeing.
Apparently, the story will be
Yes.
1.5 to 2 months, but actual pathophysiology may run over years. So same story here. 2 years is the worsening time rather than the actual time of clinical disease. Is that fine for you? Did you understand? If you understand that much, then almost we are done. Sir, you
Yes.
can continue, sir. Kamle sir, you are telling something.
No, it's okay. History of foreign body, I don't know whether he has asked or no that any time or that sort of thing.
He did not, that's okay, but he
cannot
should not miss. He should not miss.
Yeah. That is what. And
He has asked,
Yeah,
is
Yes,
it
asked
choking during feeding or otherwise?
coughing and vomiting and cough during feeding.
okay, ठीक है.
Foreign
That-
bodies, you should ask mainly if you say symptoms at the age of 4 months, you should ask, is there any other sibling in the family? They will put the foreign body. This child will not aspirate. Please ask about siblings. How many kids are there in the family? Another child was a toddler when he was 4 months. He or she was 4 months. You understand, no? Yeah, that's
Yes,
it.
sir.
Yeah.
And one more thing, he has 2-year-old child. So, is anybody investigated? If you now we contemplate something there is so because if you think any genetic sort of disorder, that also can be asked history of screening the other child, or is it necessary to screen or counseling as a part of counseling? So that should have been asked. That is what I think.
Yes.
Mandeep, I would like to ask you something.
Any questions in the question box? Just
Mandeep, is this child born of a consanguineous marriage?
No, sir. Born of non-consanguineous marriage.
And what about ethnicity?
Yes, sir.
Ethnicity, are they from North India, South India? Where are they from? Or
Sir, they are from
they're
Pune.
Maharashtrians?
Maharashtrians.
Right.
What about the religion and race of this child, Mandeep? Can you further elaborate?
So can you repeat? Sir, religion is Muslim, and sir, he's from the Pune and living in a pakka house and belong to the upper middle class family.
Do you have any further types of Muslim religion? What she belongs to? She belongs to Bohra Muslim. Do you get it?
Yes, sir.
Any significance of it?
Sir, they are mostly immigrants from the Burma.
Correct. Not Burma. From the East African areas.
Yes.
Okay, Mandeep, proceed to the examination. We'll have to finish at 4 o'clock.
Yes. So on examination, the patient is sitting on the bed with breathlessness, oxygen connected by the face mask at 5 liters per minute, intracath in the left forearm. Her vitals are as follows: temperature of 98.5 degree Fahrenheit, with pulse rate of 90 per minute, regular in rhythm, normal in volume, no radial and no radiofemoral delay, and all peripheral pulses are well palpable. With capillary refill time of less than 3 seconds, with respiratory rate of 40 breaths per minute, regular. There is tachypnea along with the subcostal, intercostal, and suprasternal retractions, with blood pressure of 102/70 mmHg measured in the right arm supine position, which lies between the 50th and the 90th centile, with saturation of 96% on 5 liter oxygen by the face mask.
Just a So what do you interpret with retraction? What do you mean by retraction? If patient has a retraction and tachypnea, if patient doesn't have retraction and tachypnea, where the lesion is in these two conditions?
So if patient has retractions and tachypnea, that is means lung pathology is present, which is mostly airway, smaller airways, suprasternal.
And no retraction and tachypnea?
So that can be present in the cardiovascular lesion.
Retraction, that means the lung elasticity is lost. Something is filled in the lung.
Yes.
Retraction. Even in cardiovascular system, if lungs are filled with the fluid, or then you will have retraction. Okay, so retraction means that the lungs is either getting fibrosed or they are getting filled with something which should not be there. Okay.
Yes. Yes.
Only one point that I would like to add for you is that if you have suprasternal recession, then upper airway obstructions are most likely. Substernal or subcostal retractions is generally a severity of the disease. It has nothing to do with localization. But intercostal retractions, whenever they are present, that means the underlying that anatomical part of the lung is involved. Please remember, if you have, let us say, intercostal retractions below the nipple, that means that part is definitely involved. You understood my point?
Yes.
So intercostal retractions have localizing value, whereas tachypnea, suprasternal and subcostal retractions are non-localizing, but they amount to the severity of the disease. Now, therefore, this disease is severe. So when you say intercostal, you can say bilateral intercostal retractions. If you are you having bilateral intercostal retractions?
Yes, sir.
You must mention that because it means that there is a bilateral disease. Understand? Otherwise, you can say infrascapular recessions or retractions. All right.
Yes.
Go ahead.
So, if may I interrupt, there's a question in the chat box. Why is this not a PID, primary immunodeficiency?
Can I take the question or you will take the question, beta?
And the primary immunodeficiency is less likely because it's present around 7 years of age. This primary immunodeficiency is associated with the recurrent respiratory infections and recurrent diarrhea at before 7 years of age.
So
PID is, it's variable. It is not necessary.
Associated with the skin infections. Skin infections like boils and oral thrush can also be present in the primary immunodeficiency disorders.
So basically, you are telling only one system that is involved is respiratory. That is the reason you are denying. You are denying? Is that the reason? Not necessarily. Sometimes we can miss this. Somebody has asked nicely, even childhood granulomatous diseases and things like that, they can present with one system involved, particularly respiratory. It can be there. But however, they are less likely, as you said, because absence of diarrheas and other multi-system diseases put it down. But we can never say it is not there in our list. It is always there. But the question is, was it presenting with recurrent fevers, recurrent infections, frequent infections, and how the infections responded? For example, what I could get from these couple of these cases is only 2 days of hospitalization was required for a lower respiratory tract disease at 4 months of age. That puts my argument on immune system that is strong and fine. Because if there was immunodeficiency, child won't be discharged in 2 days. Maybe they would require prolonged hospitalization, prolonged antibiotics. I could be wrong. And secondly, how this child responded to treatment? Can you comment? No, in these 2 years, was he responding to antibiotics, etc.?
He was responding to the antibiotics.
No, therefore, no, I agree with the question. You can get response to treatment, but it's an important input for us to even consider it higher on the list or lower on the list. They generally don't respond well to treatment. Not necessarily. In between, they can respond, but However, they may fall frequently sick. Severe the disease will be more, and they can succumb. They may or may not pull on for 5 to 7 years of age. If you consider severe SCID, no SCID, if you are considering severe combined immunodeficiency, variable, as sir said, can have the presentations, which I agree. I cannot say no to that. Okay.
Yes.
Yeah, go ahead.
There is no pallor, no icterus, no cyanosis, no edema, and no significant lymphadenopathy. Grade 3 clubbing is present in the all digits. Anthropometry, her weight is 13.8 kg with expected weight of 29 kg, lies less than third centile. Height is 111 centimeter with expected of 130 centimeter, lies less than third centile. With head circumference of 49 centimeter, lies between third to 50th centile. Impression child is severely stunted and underweight.
You said that this child has only 600 calorie gap. So why should he be having so much severe failure to thrive?
No, what is important?
See, he has a very severe failure to thrive. And your dietary history says that he has got some 500 calories deficiency also. So what could be the other factors which are related to this?
So that is chronic disorders can lead to the stunting and underweight. Chronic diseases.
Chronic disease causing decreased utilization. One. Second, his work of breathing, he's continuously having tachypnea and work of breathing is more. So he may be requiring more.
Metabolic requirements will be more as he has carried breathing and chest recessions.
Third, he has got recurrent loose motion, so he may not be absorbing. So these are things which are going to be causing this severe failure to thrive. Okay.
Yes. On head-to-toe examination, hair looks to be normal. Eyes, conjunctiva, corneal are normal. Media is clear. Nose, ear, and mouth are normal. With suprasternal retractions is noted with each breath and along with the intercostal retractions. No signs suggestive of vitamin deficiency in the form of eyes, skin, mucosa, hair and joint, bony changes. Visible scar mark is present. No obvious deformity. Skin and mucosa appears normal, and generalized wasting is seen. On systemic examination, I would like to first examine respiratory system. On inspection, tachypnea is present with respiratory rate of 40 breaths per minute with nasal flaring, suprasternal retraction, subcostal and intercostal retractions are present with the use of accessory muscles, with barrel-shaped chest, with visible veins over the anterior chest, with no visible pulsation, no scar mark, no sinus over the present chest, no tracheal deviation. Apex beat is visible at the fifth intercostal space in mid-clavicular line, just medial to the nipple. Equal movements of chest on the both sides. On palpation, no scar mark, no sinus, no visible veins on the chest, no visible swelling, and all inspected findings are confirmed. Apex beat is palpable at the fifth intercostal space in mid-clavicular line. Respiratory movements are equal on both sides, and 4 cm chest expansion is present with no deviation of trachea. Anteroposterior diameter is 19 cm and transverse diameter is 21 cm. With decreased vocal parameters on the inframammary, infraaxillary, infrascapular areas of both sides of the lung, but more on the right side than the left side. On percussion, hyperresonance sound were present over the bilateral inframammary, infrascapular, and infraaxillary area of the chest, but more on the right side of the chest. On auscultation, bilateral vascular breath sounds are present over bilateral side, along with the low pitch, high intensity leathery sounds are present both during expiratory and inspiratory phase in inframammary, infrascapular, and infraaxillary area. Moreover, the right side of the chest, along with the musical high-pitched, low-intensity sounds, more during the expiratory phase. On CVS examination, S1 and S2 is heard with no murmur, and apex beat is localized at the fifth intercostal space in mid-clavicular line. On per abdomen, abdomen is soft, non-tender, with no organomegaly. On CNS examination, she is conscious, cooperative, and oriented to time, place, and person, with no cranial nerve deficit. My final impression. She is a 9-year-old girl child with mid-childhood onset chronic, persistent, progressive, variable, severe, advanced lower respiratory tract obstructive disease with some intermittent infections, with growth failure, with stunting and wasting with probable malabsorption, requiring continuous oxygenation and regular medications, with multidisciplinary respiratory care and support. In a resolving recent worsening episode of underlying respiratory disease, my most likely diagnosis is cystic fibrosis.
No, I agree on everything. Don't add malabsorption here without you giving that history in the past. Don't add anything new in the diagnosis. You don't have to make everything of cystic fibrosis in this child. Okay. No, that should not be there.
I've given history of passing of loose motions, greasy and
When?
in the
How,
previous.
how long? No, you don't have to go back. I trust you.
Sir, intermittently for 7 to 10 days, in between in 3 to 4 months.
Okay. Why not? That is immunodeficiency then.
That
On the same lines of multi-system involvement. You can't take it to your convenience. Rightly, one of the delegate, I should thank him that he has raised the question of immunodeficiency. When you have a multi-system disease, beware. And secondly, don't say wasting with probable malabsorption. Wasting can be due to many things. Wasting and stunting. Don't mix the two. You understand now, with growth failure and stunting and wasting. That's fine.
Yes.
Don't say due to what. It could be multifactorial.
Yes.
It need not be one, right? Except for that, fine. You can't say mucociliary disorder, cystic fibrosis straight away. At least you can say most likely to be cystic fibrosis. That's fine. You should say bronchiectasis. You have not mentioned that. See, bilateral bronchiectasis because you have latheric repetitions. Why you want to say lower respiratory tract obstructive disease with bacterial infections? Is bronchiectasis? No, there is a term for it. You have clubbing. What else you want? If you have a clubbing, bilateral airway disease, and with wet sputum and bilateral coarse crepitations, what else you want is an undergraduate diagnosis, and nowhere bronchiectasis is mentioned in your diagnosis. So please write it is bronchiectasis, and the cause of bilateral cause of bronchiectasis could be cystic fibrosis. Severity of the disease, it is definitely severe disease with limitation of activities and absence of school. Correct? No, sports and schools, she's having absence, isn't it?
Yes.
Performance is affected. And nutritionally, she's grossly undernourished along with growth failure because there is stunting as well. This much could have been fine, right?
Yes.
Now you tell me how will you evaluate further?
So before that, let's see. This child has some musical sound. You didn't tell us whether it was what it is likely to be. Is it stridor? It is wheezing.
It is most likely wheezing due to the air trapping in the smaller areas.
No, wheezing means you have to confirm it in the findings.
It is bronchi, means in auscultation. Auscultation, it is present musical sound, so it is bronchi.
Bronchi. Is it bilateral, symmetrically equal, or is it somewhere it is more, somewhere it is less? Because we expect it will not be symmetrical, very symmetrical. And
The
even
more on,
preps are equally, or is it symmetrical?
the more on the right side than the left side.
But you didn't display that in your finding. You have to be more specific. At your level, you should be more specific in your finding.
I mentioned some more about the right side of the chest.
Okay. Okay, go further. Go further. For approach, now further, now you have given a diagnosis. Now, how will you confirm your diagnosis?
So, first we will do the chest X-ray and Ethnicity of the child.
Do you have films?
No, no, sir, I don't have films.
Okay.
So, what are the investigations to do? Start from first.
CT is done or not yet done?
The CT is done, but I don't have films right now.
All right.
So, first we have suspicion of the cystic fibrosis. We have to go for the 2 times sweat chloride test.
Next, routine investigation will be done or not? Hemogram. Will you do ABG, VBG, whatever you want to do? Because you are giving oxygen. Would you like to go systematically, do X-ray and then go further?
So first we go the
Other symptoms like some liver function also you like to do.
so first we will go for the C.
No, 1 second before you go further. SpO2, was it recorded?
Mandeep? Hello, Mandeep?
I think we lost him. Till he comes in, we can take some questions from chat box. There has been some questions which are predominantly that can this be HIV? The answer is very much yes. Nobody can prove or disprove a diagnosis of HIV in any child because this is the commonest cause of immunodeficiency, and only serological tests can be done to prove or disprove. But the question is on examination, absence of generalized lymphadenopathy, predominant involvement of one system, and bronchiectasis is not common in HIV. In fact, it is tuberculosis plus HIV, if at all you want to think of bronchiectasis in HIV. Otherwise, it is an interstitial ILP or PCP. They all present pretty early. You go ahead, Mandeep.
So then we will do the HRCT of the scan that shows the bronchiectasis. After that, for rule out the cystic fibrosis, we have to do the sweat chloride test at 2 duration, which if shows more than 60 millimole per liter, then it shows a definitive diagnosis of cystic fibrosis. Then we can do the CFTR gene mutation genetic test or nasal electrode potential difference we have to check.
I think there's a question. You should not wait if you suspect cystic fibrosis because you should get the diagnosis early. That's simply because if you wait for long, then other investigation for other diseases will go on. So therefore, if there is a suspicion of CF, we should go ahead and test because iontophoresis or sweat chloride test is quite cheap and is affordable. Only final diagnosis may be a little expensive, then that's fine. That's fine. Mandeep, you can carry.
Next, we will go for the after diagnosing cystic fibrosis, we will go for the treatment part. Treatment, there should be multidisciplinary team approach involving the respiratory chest physiotherapy, nebulization with the hypertonic saline, and tobamist and antibiotics according to the sputum culture sensitivity. And we have to monitor oxygen saturation of the patient. Then there are some immunomodulator agents for the cystic fibrosis like ivacaftor, lumacaftor that can be used for the cystic fibrosis.
Okay, basically, cystic fibrosis will require growth. One. Second is going to be your lung has to be protected. Further damage of lung should not happen. Then third is the disease modification. Fourth, you'll have to give preventive therapy so that it doesn't get a recurrent infection. So what type of preventive therapy you give so that it doesn't get recurrent type of infection, recurrent infection?
So we mostly continue macrolide antibiotics at the 5 milligram per kg for the prophylactic, and we go for the regular sputum examination for Pseudomonas aeruginosa and bacterial infections.
So basically, this child has received immunization in a government hospital. Would you like to immunize him against some diseases so that?
Yes, we will. we will like to immunization against the pneumococcal and influenza vaccine and for the typhoid vaccine. And lastly, at 10 years of age, human papilloma virus.
Okay, and further, chest physiotherapy, you know different positions of giving chest physiotherapy? Now this child has lower lobe involvement mode. I don't know, what was the scan, MRI scan like? Which lobe was more involved?
Lower lobe involvement.
So if lower lobe is involved, how is the chest therapy given? So physiotherapy is the most important part.
Physiotherapy.
Tell us. Chest therapy, before chest physiotherapy, you should always do a hypersaline
Nebulization, hypertonic saline nebulization.
There are many instruments which help aid in giving chest therapy or chest physiotherapy also. They may be costly, but if you want to prevent progression of disease, we may have to use them. Okay.
Yes.
Go further.
So then we have to continue Creon for the malabsorption. Multivitamins as fat malabsorption lead to the vitamin deficiencies.
Have you demonstrated malabsorption in this child?
So there is no sign suggestive of malabsorption vitamin deficiencies, but there is history of greasy stools that can be. So
would you like to get a stool examination done?
Yes, we will like to do stool examination for fat and Sudan stain.
So that's what I said. It should go systematically when you are investigating a child. So that will help you in treatment. Okay, and she is 9 or 10 years old child. So would you like to do some other test also? Something related to pancreas?
So we would like
you should monitor
blood sugar levels for cell.
Done because as pancreas get destroyed, further sugar may also go up.
Yes.
Go further.
So yes, sir.
No. Subramanian sir is there?
I am there. Continue. Let him continue.
Okay, continue.
Then, sir, we have to go for the immunomodulators like immunocaptor and lumicaptor. And there's one new immunomodulator, tazecaptor.
Yeah, you're talking about medicine. Would you like to do some counseling of this child, parents counseling? Because what you are talking about, these medicines are so costly. Will this parent be able to afford?
Mostly, they are not started on like immunomodulators, but you have to counsel the parents about the disease prognosis and about that.
So did you counsel this patient? How are you going to counsel this patient?
So we have to counsel the parents about that this is a inherited disorder, which is mostly present from birth, but it's manifest in at 7 year of age. This is yes, sir. We have to continue on the multidisciplinary team approach with the chest physiotherapy. We have to monitor SpO2 every time. We have to continue with the nebulization with hypertonic saline, and if there is exacerbating events, she has to visit the hospitals. And for growth, she has to continue the growth chart monitoring, and on the nutritional or dietitian advice. And we have to also advise to the endocrinologist.
So because most important part is going to be counseling in this patient. This is a chronic disease where they have to really follow up well in this condition. Otherwise, they will not have a good prognosis in this.
one question parents may ask, doctor, how long this oxygen will go on continue? So anything can be done for that because child is oxygen dependent. So whether child has gone into some oxygen dependent state, so anything can be done. That is a question parents can ask because that is the crux of question. So how will you counsel this one?
This patient has already progressed to the requirement of oxygenation that we can't revert back to the normal lung. So we have to continue with the oxygenation, but we can just halten the increased requirement of oxygenation.
Does exercise help in decreasing oxygen requirement?
Yes, sir.
Will exercise help in building his lung capacity better?
So that chest physiotherapy can decrease.
Breathing exercises should also be done so that his capacity increases. You told us there's a clubbing in this cell. So why should there be clubbing in this cell if we never had hypoxia, cyanosis as such?
So this patient mother is already monitoring oxygen levels with the pulse oximetry. So that's why.
What could be the other reason for clubbing? What is hypoxia?
So that can be inflammatory associated.
It's a chronic separation which is going on in lung. We call clubbing also. So can lead to clubbing even without hypoxia.
Yes.
Go further.
I think as a PG, you have two things to do. One is you split the two, manage bronchiectasis and manage cause of bronchiectasis. Understand now, Mandeep? Then it will be very easy for you. Management of bronchiectasis is essentially same, whatever may be the cause of bronchiectasis. That is general, posture, drainage, airway clearance techniques in the form of, there are chest physiotherapy, which is manual. Now we have got chest braces with, vibrations, which you can give it to them. They will dislodge the sputum. They are available, chest braces you can ask for. And then you must teach them how to do physiotherapy and low voice physiotherapy to be done and frequency and how assist the child. This is one part. The second part is management of colonized organisms. This is common in all bronchiectasis. It could be commoner organisms or it could be like Pseudomonas in cystic fibrosis, whatever. But there has to be some kind of management of flare-ups or management of the colonized organisms in bronchiectasis. This is common to all bronchiectasis, remember. That is 2. Number 3 is nutrition and support. This is also common in all bronchiectasis because it is a protein losing or catabolic state and they have to be on high protein diet and supportive care. These are the 3 cornerstones. To know the organism, either you can do sputum culture. The issues are quite cheap, readily available. Oropharyngeal flora mixing is a challenge. Pharyngeal and oral flora can come in the sputum. You understand? So, and perfect technique in young age is a challenge. So in such cases, you can go for bronchoscopy and BAL and grow the organism, which I think you did not highlight, but it's all right. Everywhere we should not push bronchoscopy for you. So therefore, I'm telling you that's actually a correct way of managing, and you can do lavage and then liquid biopsy of lavage is nothing but liquid biopsy of the lung. Understand? So surface biopsy. So you can take and then grow the culture and then decide accordingly. It may also give sometimes hint to the cause of bronchiectasis. Suppose it is non-CF. The bronchoscopy will give clue to the diagnosis sometimes. Is there, are there hemosiderin laden macrophages, the stains that you use? Understand? So don't worry. But there are many other causes that you can come out when you do bronchoscopy. So do not worry about this particular.
This child has undergone bronchoscopy and BAL examination. So do you have any information on the report of bacterial growth on the BAL sample of this child?
She has Pseudomonas growth on the BAL examination. And MRSA.
The child has staph as well. So Staphylococcus aureus and Pseudomonas she is already colonized with. She is already
Yes.
infected.
So that further strengthens your hypothesis of cystic fibrosis, apart from your investigation of cystic fibrosis. Correct? No. So based on the organism also, you can have some hint. So this is very, very important. Now, suppose you don't find CF, then it goes to the whole Pandora box of investigations to find out the cause of bronchitis. If you don't find anyone, you call them as idiopathy. Is that clear?
Yes, sir.
Go ahead. Anything that you want to present means you tell, otherwise we can conclude.
This is all.
Okay, fine. Any questions from anyone? They can unmute and ask, then he will be there to answer. So I will summarize in 5 lines if it's getting over. Shall I summarize? Yeah.
Yes, sir.
Yeah, see, what is important is I will tell all the postgraduates, think of the common diseases first. Don't rush to primary ciliary dyskinesia or rare diseases first. First, look at the presentation of the disease, not the disease. See, anemia is the presentation of iron deficiency, which is a presentation of bleeding, and bleeding lower GI is the final diagnosis. Is that fine? I think you understood the point. So don't stop. Don't mistake a label for diagnosis. Don't mistake a presentation for diagnosis. This child has presented with an airway disease, airway plus parenchyma, and an ectasia or a bronchiectasis and bilateral severe disease. So that is the presentation. Clear? Now the cause of this is the disease, which is probably cystic fibrosis. The management is, again, if there is no specific treatment for cystic fibrosis, it will fall back on the management of the presentation, which is management of the bronchiectasis. And I'm simply summarizing it for you. If you write like that, it will be fantastic and simple. So keep it simple. Any doubts you have got, Mandeep, you can ask me.
Yes.
Is there any questions unanswered in the chat box? Just see now.
Say every patient who doesn't have, who has short stature or failure to thrive, you don't have to refer to endocrinologist. What are the markers? You told us that you refer to endocrinologist. So what are the points which you should take in care, in consideration before referring?
So we will, short stature, we have to go for the growth velocity. We have to check if growth velocity is normal for the taste. And that can be due to the family or constitutional. Then if growth velocity is less, we go with the organic causes. Then we have to see that short stature is due to the upper or lower segment ratio disproportion.
So you didn't mention that. See, your upper segment, lower segment ratios and proportion would have told us that what is happening. Second thing, you didn't tell us about what has happened to her pubertal thing, because she's 9-year-old. So what has happened to her? If she pubertal would have been earlier, late, we don't know is there an endocrine problem or not an endocrine problem. So any short stature, you're not supposed to refer to endocrinologist. You should try to use it, try to analyze yourself and then decide where to refer and how to refer. Okay?
Yes.
Mandeep, I want to ask you a question. What precaution or warning you will give to the parents or ensure when the child is hospitalized for 2 to 3 weeks and needs ongoing nebulization at hospital? So my point is, do you have any risk associated with shared nebulization devices?
There can be extra growth of the another organism due to sharing of the nebulization with.
Each particular organism is transmitted through shared nebulization devices and fluids, and is detrimental, can really be fatal in the case of cystic fibrosis.
Burkholderia species.
Correct. That's the organism. So this has to be meticulously followed. So the acquisition of new infection by close contacts must be avoided from all possible sources in cases of cystic fibrosis. Okay.
When we are at nebulizer, suppose he's using his personal nebulizer, what precaution you should take while when you are using personal nebulizer also in this case, so as to prevent the infection? Obviously, what we are talking about is prevention of infection, even if he has personal nebulizer.
So we have to advise mother to keep the nebulizer clean and clean with the warm water. And every time she use nebulizer, she has to maintain the safety precautions.
Basically, nebulizer has to be kept dry. If it is wet, it will grow a lot of organisms. So it has to be dried every time. Your nebulizer tubing and everything has to be kept really dry. Okay.
Yes.
So anything else you want to ask? You can ask also.
Does she have sibling, Mandeep?
Yes, she has a 7-year-old female sibling.
So is she likely to have a cystic fibrosis again?
So she doesn't have any presentation till right now.
So this child also didn't have any complaint till 7 years of age.
So
how would you
autosomal
like
recessive.
to exclude possibility?
Yes, we will like to exclude the possibility with the doing sweat chloride test and genetic test, mutational.
Mandeep, one question. This child has
Yes.
so much nutritional deficiency. Still, this child doesn't have anemia. Why should he not have anemia with so many nutritional deficiencies? Failure to thrive and all those things.
So, mostly patient is on oxygenation.
So oxygenation is going to decrease chance of anemia.
It doesn't decrease the anemia, but hemoglobin saturation remains.
Does hypoxia stimulate something which produces more of a?
Mandeep, your answer should be there will be polycythemia in anemia.
Okay.
Because of chronic hypoxia. You understand?
Yes.
In fact, the red cell mass may be more for given anemia. I don't know how to tell that. It's like telling obesity in a low birth weight.
So here you may have to supplement iron if you find PBS which shows microcytosis or hypochromia. You don't have to go by HB number. Okay.
Yes.
Because it will be
Yes.
more of erythropoietin produced due to hypoxia.
If this child starts growing with the intervention, then you will start getting uncovering of many nutritional deficiencies. You understand? There could be restriction of even requirement or disadaptation, and there will be, as the child improves, every nutritional requirement is going to crop up.
Yes.
So should we conclude?
Yes, I think we should, isn't it? Okay. Thank you so much
Yes.
for making me meet the junior most in KM right now, taking me to nostalgia. Thank you very much.
Pleasure, Subbu sir, to have you to guide our students. Thank you so much.
Thank you. Thank you.
Thank you, sir. Thank you, everyone.
Thank you so much, sir, for coming up. Well presented, Mandeep.
Thank you.
I think, like sir is saying, you are presenting to him as an. Thank you so much, Vijay Kamal, sir. Thank you much, Mr. for the students fantastically every time whenever.
Thank you very much. Thank you, Sarita.
Yes. Thank you, everyone. Shall I end? Thank you.
Yes, thank you. Thank you.